starting the session, welcoming everyone to this learning session of the Consortium of Universities for Global Health. It's a pleasure to be here with you and run this session together with a few of our key partners in the emergencies learning work. My name is Dr. Heini Utunen. I'm the Learning Unit Head at the World Health Organization's Health Emergencies Program, where I've been functioning for 10 years in emergency learning area in a number of epidemic responses as well, running the pandemic learning response during the COVID-19 pandemic and responding to numerous other health emergencies and health events. And I'm joined today by my colleague Melissa Adias, who's been kind enough to arrange this session together with the CUGH organizers. So many thanks for Melissa and Susan for making this session happen. And it's a great honor to have our World Health Organization's Collaborating Center for Digital Learning in Health Emergencies joined today by Professor Bruce Struminger and his team from the University of New Mexico, the Institute ECHO. And this session is a joint session between the two of us, the World Health Organization and our collaborating center in New Mexico, and we'll have an interesting story of learning work across a number of real-time, just-in-time learning response that we mounted together in the past years, and we'll talk more about this work during the sessions. And we have a special guest joining today from the University of Nebraska's Medical Center, Dr. Nada Fadul, who's gonna provide us insights on how the work in response to the Sudan conflict and crisis in the past years has been implemented and what has been the ECHO modality that her team has undertaken amidst of the Sudan conflict. And these sessions all together provide a flow of activities that we've planned and designed together in the learning space. Us in the World Health Organization, we've worked with our scientists, experts, and technical teams of various areas of the emergency preparedness and response at the World Health Organization and produced knowledge materials for the world. And it's been a massive scale dissemination of knowledge components for different epidemics, pandemic, and health emergency events. Then our colleagues from the WHO Collaborating Center for Digital Learning in Health Emergencies at the University of New Mexico have taken these resources and provided live, interactive, virtual classes together with the experts on various topics. And Dr. Bruce will talk about this work in detail. And then we'll hear case studies of various sessions and topics that the ECHO Institute has provided for this work area. So this is the plan for about 2 hours. And before we get started, I'd like to have my colleagues joining here introduce themselves. And I'll hand the floor over to Professor Bruce Struminger. Over to you.
Thank you, Heini, and welcome everyone to today's session. We really appreciate you joining us for this discussion. My name is Dr. Bruce Struminger. I'm a professor of internal medicine in the infectious disease division at University of New Mexico. I'm one of the associate directors leading our global health initiatives at Project ECHO, which is an initiative based at the University of New Mexico. And as Heini said earlier, I'm the director of our WHO Collaborating Center for Digital Learning in Health Emergencies. And really happy to be here, Heini, and back to you. It'll just be me today. My colleague Amy Groom is, because we are helping respond to the Mpox emergency right now. We have a planning call that she's joining right now with your colleagues in Geneva and Brazzaville. Back to you.
Thanks so much, Dr. Bruce, and lovely to have you here. And this is the agility we have in the emergency space. We are repurposing and working against the objectives that are in the table. And at the current time, the ECHO Institute here is strongly supporting our mBox response and running a number of virtual classes that are of critical importance. I'll also talk about that work later in my session. Professor Nada, over to you.
Yes, good morning, everyone. This is Nada Fadal, a professor and assistant dean at University of Nebraska Medical Center. And I'm originally from Sudan, so I'll be talking to you today about the emergency response Sudan experience. Great to be here with you, and thank you, Heini.
Thanks so much, Nada. And I'll hand over to my colleague, Melissa, who's behind the scenes organizing this session.
Hi, everyone. Really great to meet you. I'm joining from Geneva today, and it's a pleasure to be with you all for this webinar. Looking forward to it. Thanks.
Lovely. With this background and also appreciating the Consortium for Universities in Global Health for their hosting of the session, I will get started, and I'll show you the more detailed plan for today. I'm talking first about the knowledge transfer work that I've been leading in the past decade in the World Health Organization, and how the impact it has, and how it has served the emergency response in the World Health Organization in the past decade. And it was lovely to see many of you providing your background. I see we have a lot of infectious disease learning professionals and others from around the world in the session, and look also forward for your comments, questions, and interventions. Melissa will help me to address your questions and comments if you drop them to the chat. Then my session will be followed by the introduction to the ECHO learning model, which is Dr. Bruce's topic here. We'll then next hear from Dr. Nada, who's gonna elaborate how this ECHO model serve the purposes in Sudan and still continue to be the model being used across a number of health interventions learning in Sudan and beyond. Then we'll also hear about other work areas where the World Health Organization and our teams globally have been able to benefit from the ECHO virtual class model across our work areas from numerous works that are also ongoing as we speak for the post-long COVID conditions, for the laboratory diagnostics, for the workforce development, and many more. And then we'll have a chance to exchange on these, get your inputs and comments, and have a short wrap up in 2 hours. I'll mention that all the World Health Organization's events abide by the Code of Conduct of zero harassment, and we have zero tolerance on any types of harassment, including sexual harassment. And if there is any inappropriate behavior in the session, we'll have to remove such participants. We pay a high attention to the Code of Conduct within the workforce and also in the context where we work, and we always take this up in every WHO session. I'll now go to my story of knowledge transfer for health emergencies in the context of the World Health Organization's Health Emergencies Program. And it is just 10 years ago when I first joined the World Health Organization as a training staff during the Ebola West Africa outbreak. And the task there was to take WHO's science and evidence, translate it into the learning elements, and provided for the frontline response in West Africa for the Ebola outbreaks, multi-country outbreaks. And that was the starting point for my journey at the World Health Organization just 10 years ago. And that time we didn't have any platforms or technologies through which we could have disseminated WHO's technical guidance in simple, short, editable, adjustable formats. And when the Ebola outbreak of West Africa was declared over in 2016, I started systematically developing the knowledge transfer, health information dissemination work area. And it's really culminated into the pandemic learning response that has really become the largest learning response, largest learning program this organization has ever conducted in the 76 years of its existence. And of course, I've been joined by dozens of colleagues from within my team, but also from other areas of WHO who have made sure that we've been ready and equipped to mount this learning response. And we've now lately started calling this real-time, just-in-time learning with these words, just-in-time learning for health emergencies. And we've even produced a very novel WHO guidance on this topic, and I'll also introduce it later in this session. And I thank Melissa and the talented team here behind, in particular the openwho.org team who've helped to produce this session. So following the Ebola West Africa, we identified a very clear need to have a rapid response learning platform from the WHO experts to the world. And we went forward. I've been leading this ever since, and established a massive open online learning platform who's the openwho.org. And the prime purpose for this platform is to function as the central hub for emergencies learning for the World Health Organization. And we prepared this platform so that it would be ready to scale up during any major events like the pandemic. And when we first launched it in 2017, of course, we didn't know about the pandemic looming out there. We knew that the pandemic is only a question of when, not if. But of course, we couldn't have known that the pandemic, such as the COVID-19 pandemic, would hit early 2020. But by that time, this platform was up and running, already very successfully catering for number of different health events and outbreaks, including Ebola, cholera, meningitis, plague, and many others in the African context and beyond. And it's really packaged, short and simple, 2-hour, self-paced, short courses, all technically cleared by WHO experts and based on WHO science. And it's available for anybody who wants to access it. And we've really worked on accessibility also from the point of view of languages. We currently host 75 different languages. And 1 year ago, the Learning Performance Institute gave us the Learning Platform of the Year title for the achievements we've reached during the pandemic, and it's a great legacy of the work we collectively have done across the health emergency areas. And our learning contents include anything from natural disaster, slow onset, or man-made disasters into epidemic and pandemic response, emergency management resources, as well as health security preparedness, international health regulations, and dedicated country response channels. For instance, the latest channel we've launched is for Afghanistan. So our office in Afghanistan hosts learning for various health events in Dari, Pashto, and other languages. And we are the host for these resources. We also host a very popular channel for the Ukraine response. We have more than 30 learning resources available for the current situation at hand, the health impacts of the war in Ukraine, and many more. We have continuing professional development accredited courses, and we are humanitarian path accredited learning producer, and we've also worked on the quality markers of the contents of our courses, and they are always available in self-study formats, so they are not requiring presence at this certain time. They are not synchronous classes. That part of the work has been taken forward by the Institute ECHO colleagues here, and we will hear interesting stories how that has been working. We have learning content for the infectious diseases, the deadly diseases in particular, the diseases that are in the anticipating next pandemic list, 9 diseases. And we have the learning contents for the biggest infectious killers, as you see here. We've organized a number of courses across tuberculosis, malaria, HIV/AIDS, and diarrheal diseases, as well as the pandemic learning response, which was really a major learning effort of the whole organization in the years between 2020 and 2023. And these resources are there for anyone to take and adjust. And why this has worked, the knowledge components have worked so well. It's really because they are there in the multiple different adaptable formats, in multiple languages, as well in the multi-channel format. And they are also in multi-pathogen formats that make it easily accessible for any learner who wants to go and take the courses and visit WHO science around different topics. The platform has been now up and running for 7.5 years almost. We've surpassed 300 courses at one point. We've now sunsetted some of the earlier courses, but we have in total more than 300 course topics on the platform. We are addressing 40 different diseases, have more than 100 courses on epidemic and pandemic diseases, 25 different learning channels, 17 channels for country-specific content for Suriname, Somalia, Indonesia, many more, and they are all within reach on the platform. As said, we have 75 languages, and we've translated more than 24 million words, and we haven't used machines for the translation. We've used humans, and this has been the accuracy that WHO's science has required. But of course, going forward for the future, we are looking into the more machine translation, machine induced learning as well, minding that it's the human stewardship that needs to be there at all times to vet and clear the materials so that they are not only machine induced, but also human proofed. In total, we are nearing 9 million course enrollments, that we will surpass that 9 million line in 2 weeks. And we have very active learner base. We have about 2,000 new learners joining every day. And half of our learners complete their courses and take the course certificates with them. So it's been super well working for the world, in particular during the pandemic. As you can see here, the growth during the pandemic years was exponential. During 2020, we went from about 120,000 learner enrollments into 4 million, and we added like 1 million more learners every month. It was really a massive undertaking and a big effort in terms of producing content, about 50 COVID-19 courses and all other infectious diseases and health events supported at the same time, but then also making it available in the formats that, for instance, the COVID-19 vaccine rollout could be supported in the early 2021, so that each country that received the Solidarity vaccine and other vaccines could have the tools to manage the vaccine deployment at the right time, at the right place, in the right formats. And it's been a major learning curve for us in the team, but also for all the scientists who've been working with us on the learning content. And we keep growing and producing learning for multiple and a number of contents. These are a few of the highlights of the work during the pandemic. We've been taking stock, thanks to our amazing data colleagues over time, Paula, Jason, Gui, and Rochelle, who've been working on this area. We've been able to really establish who are our learners, why they are here, what do they need, and how have we been able to meet their learning needs. And we've looked at the different statistics also to see the change that the pandemic brought. And I think in the learning world, especially in the online learning world, nothing is the same anymore. The pandemic really changed the kind of learning into more really nuggets of learning, piecemeal attention, but also more presence and attendance online than ever before. And this is, of course, a big demand for us, the learning organizers. How do we supply our learning resources so that they work for the end users, the extension workers in the frontline response, community volunteers, and others who need these resources for their learning response. So when we look at the global attendance to the online learning, we could see that when we take the per capita numbers, the more remote island the country is or the territory is, the higher enrollment per capita we have from those islands. And it's true to 14 out of the 20 highest use country cases in the platform. For instance, from the island of Guam, 7% of the population has registered on OpenWHO. And we cherish this reach we've been able to achieve. Also because we see that the learning really reaches every corner of the world, and we have learners from every WHO member state and territory, and it's been quite magnificent to see this evolvement. Before the pandemic, majority of our learners were male, but pandemic brought more women. Also, when we surveyed the learners, we are now at 50-50. At points of time, the women are surpassing the male learners. And the women really in the surveys, in the qualitative surveys, have said that the flexibility of the self-paced learning makes it possible for them to attend and achieve their certificates and complete the learning. So this is also a very flexible format. We increased the enrollments from low and middle income countries, accounting to approximately 70% of our learners deriving from low and lower middle income countries, which is also important for WHO's Health Emergencies program. Our priority countries are located in the global south and in many of these countries. And there also the prevalence and many endemic diseases are in number of those countries. We really made it possible to adapt, contextualize, and share the learning materials by learners themselves. And we have amazing use case illustrations of this from the neglected tropical diseases, from the immunization materials, and many more. And think that this is one of the largest legacy of the work we've done. Before the pandemic, we didn't notice we had much of the learners younger than the age of 20, but now it's up to 10% of the learners are younger than 20. This is self-reported age. The same goes for the learners older than age of 70. We went from 0 learners, 70 plus, into about 5%. So those most vulnerable to the COVID-19 actually joined the learning platform. And here you can see our work together with our country offices and regions. Our serving countries channels currently feature content in languages of these countries and for their workforce. And WHO's country offices have tirelessly worked with us to translate and host dedicated learning for different country contexts, and we continue this work. We've noticed that our learners use the original content of our materials, and we call it learning multiplier effect, where our online learner takes the materials, contextualizes, translates, repackages, and shares them further. And in the recent study that our collaborators at the Stanford Health Education Center were able to complete, we noticed that on average, each online learner that had registered on our learning content, in average shared the content with 9 other people, not on the platform, but outside of the platform. Thus, the multiplication we could calculate in this work is about 9-fold from the numbers that we are reaching directly through the platform. And this is because of the bandwidth, access, linguistic, and other issues. And we feel that the original content sharing is one of the most demand topics on the platform. Over time, we've witnessed different ways of multiplication of the materials on the platform. And it's everything from public health institutions to the university courses. The Peace Operations Training Institute is making books out of our materials and providing the military peacekeepers with the PDF and printed books on Ebola, infectious diseases, and beyond, so that the peacekeepers could access the basic science of how protecting themselves in events of health emergencies, for instance. And we've really noticed a lot of uptake and use of the materials from outside of the platform itself. Now, a few words, just because we mentioned Mpox, and this is the public health emergency of international concern that we are currently responding to. And what it means learning-wise, we have various learning resources for the Mpox in a number of languages, also contextualized for the context where the outbreak is circulating the most aggressively, in this case, in the African context. And we have a very keen uptake of the materials, and we are looking into even more expedited way of disseminating the content. And here just a few figures from the time when the public health emergency of international concern on Mpox was declared mid-August, and how the learning uptake has evolved ever since. This is August data. But we see a keen uptake of learning content by professionals, health responders, and others in the field of work. And now what Dr. Bruce and the team here is from the ECHO Institute side is doing is translating these contents together with scientists into the live classes where the experts join the workforce in establishing what it is that we now need to do for various aspects of the work, the laboratory diagnostics, the surveillance, response, etc. And here's just to show how, for instance, in the African countries, how the Mpox learning content has been, the registrations and enrollments to the courses are from around on the Africa. You see the higher the circle, the more enrollments, and of course the big populations like Nigeria, Ethiopia here are very important countries of accessing the learning content. And we have similar for the Ebola outbreaks. It's the epicenter of the disease outbreak and the neighborhood countries where the keenest uptake of learning content is. And we are expediting the learning material production so that at the onset of any event, we are having the critical resources at hand for responders, in particular in the infectious diseases. And here's just percentages-wise what type of learners we have: healthcare professionals, students. This is self-disclaimed affiliation. We have health ministries, health experts, volunteers, NGOs, other ministerial staff, health institutes, and WHO staff attending. And we have quite young learner groups. It's often the leading age groups are the practitioners between 20 to 29 years of age. And this particular one is for Mpox, but we have similar trends for any courses. And when it's more specialized course, for instance, clinical management, we have up to 70% of the enrollments from healthcare professionals. And we've done a lot of surveys and studies to understand more in detail who are these people. Since it's fresh still in the mind, this pandemic learning response, and we are currently performing various after-action reviews, a WHO method to understand how did we function in the global convening role we had for the COVID-19, we are taking actively stock on how this happened, what did we achieve and how, and what were the methods that worked the best. And we've gone through a major after action review on infection prevention and control learning, and now also doing it in the various other areas. For instance, in the infection prevention and control area, we had 1.6 million learners registered on IPC only. So it's we are talking about massive scale here. We feel that what we've done through this platform, massive open online courses for the large audiences, it is really an example on how knowledge transfer, when at the right time for the right audiences and expedited, can really work as the first knowledge component in providing emergencies learning content for the large audiences. And it serves really as an example that we want to also learn from and keep establishing what is the learning need in the future outbreaks, in the possible next pandemic when it hits, and how this learning experience teaches us the lesson for the next ones. The self-paced learning works particularly well. It's the first knowledge component, and then we need to go in the more adapted skills building type of learning that also ECHO Institute here is supplying the WHO and other workforce with. We feel very strongly about the equitable access, that we are removing actively all barriers for accessing. And it means we are packaging everything low bandwidth, smallest nuggets possible, multiple formats, languages, as mentioned earlier, and also in formats that work for the learners. And following this experience, over the past 2 years, I've been leading the development of the WHO's implementation guidance on emergencies capacity building. This is the name, the title is the name of the guidance, and it's on approaches for just-in-time learning response to health emergencies. And this is a stock taking of 10 years of accumulated literature, scientific evidence on just-in-time learning, and we plowed through tens of thousands of articles, commissioned scoping reviews, systematic reviews, and a number of other studies in order to understand what is the what's the essence of the just-in-time learning in health emergencies as it's happened in the past 10 years. And we've now, I'm actually very happy about this. This guidance was launched last week, and we've put here, we can also put it on the chat, the direct address where you can obtain this guidance. And it's really there to inspire anybody mandated in emergency response, particular health emergency response, to think through what is the capacity building element at different cycles of the emergency response, and how the learning can be embedded to all stages of emergency preparedness, response, recovery, and the stages beyond. And this is the kind of a work spirit we want to take forward, and this is the evidence foundation for our own work. And this is very WHO style of producing guidance and good practice evidence recommendations, which are in the guidance. I'll show them here. These are the 5 guidance recommendations we've proposed, and we've had an amazing panel of experts. More than 100 experts were advising this guidance, also providing the operational knowledge on what needs to be done as per just-in-time learning. And we've really looked into the material, how appropriate the materials are, how relevant, how evidence-based, how we can ensure the rapid dissemination of any health information, knowledge, and tools in health emergencies, and how to optimize the learning capacities and opportunities for workforce, establish the networks. This is one of the prime outcomes of the guidance, that the networks for learning response need to be set up between the health events themselves for them to work well. And then also how to explore and deploy innovative technologies and methods for health learning, health emergency learning. And these are, it's a great guidance, I have to say, and I hope you can refer to it and utilize it yourself. And beyond the guidance work, we are publishing actively on various aspects of our own work. And now latest, we've been also working in partnership with the Stanford Health Education Center in looking into the adaptation, motivation, low-income country enrollments, and utilization of our learning resources, and how they serve the purpose of situational, momentous, continuous adult learning in health emergencies. So you can visit these and find these publications also from Open WHO publication tab from our site. And I invite you to also join this work area in just-in-time learning, research, and understanding of the needs and requirements that are out there. And that's all from my side. Connect me in LinkedIn and follow me. I mainly share our work in that space, and hope you have a chance to also contribute to the thinking of what works and for what type of emergencies, and how this work area, how we prepare for the next pandemic, and how we can together make the world safer from health emergencies. And this is the call for action for all of you to join us in WHO in different functions. We are only so strong as are the people who work with us, and I hope there are chances for you to join and deliver emergencies learning at your end or together with us. So thanks for that, and I'm happy to take a few questions if any. And I'll while others present, I promise to go to the chat here. There's a lot there. So happy to take questions from there. Melissa, have you been able to see any questions that I could shortly take?
We haven't received any specific questions yet, but a lot of nice greetings from everyone across the globe. A reminder, you can put your questions in the chat or through the Q&A function, and we're happy to respond.
Thanks so much. And we'll also share the links. Yeah, thanks, Melissa, you've been sharing. So Melissa here has been sharing a few of our links that I mentioned during the session. And please explore and share the openwho.org as well. It's a great resource of knowledge materials. So that's all from my side. I'll now hand the floor over to Dr. Bruce, who's gonna talk about how the ECHO model has been established at the University of New Mexico and how it works. And then later we'll explore also how in particular it's been applied to the World Health Organization's context. And it's just now that we are celebrating 1 year of joint collaboration under the WHO Collaborating Center status and Bruce is the director of the WHO Collaborating Center for Digital Learning in Health Emergencies. And we've had a tremendous possibility to collaborate during the past year. I also thank you, Bruce, and your team for the amazing work that you've tirelessly put forward across the globe to service the public health imperative in health emergencies and beyond. And it's been a great pursuit so far. The ECHO Institute and the project ECHO has been working with the World Health Organization for more than 5 years already. More than 450,000 learners have joined the live classes, and it's a huge powerhouse that we have in the WHO Collaborating Center in New Mexico. So really thanking you for your vision and investment and effortless work together with us and so many other WHO technical teams. And I'll hand the floor over to you to present the ECHO model. Over to you.
Thank you, Heini, and thank you everyone for joining us today for this learning session. I want to thank my Global Health Initiatives team at the ECHO Institute at University of New Mexico. We have a team of about 10 or 11 people that support this particular global health and emergencies work, a small but mighty team. And we've been on an incredible learning journey ourselves, in particular over the last 4 years. 4.5 years along with the WHO, and since we began formal collaboration responding to COVID-19 and a number of other health emergencies. So I'm going to share initially an overview of Project ECHO and Just going to bring my slides up. So Project ECHO, which was created over 20 years ago in 2003, is a case-based virtual community of practice approach of very interactive small group learning. And that is what we've been focusing on from 2003 up until 2020, when the COVID-19 pandemic engaged all of us across the world. And we had to think differently at that point about digital learning. And I'm going to talk a bit about the traditional ECHO model and digital learning and how we've expanded and had to be flexible in what we were doing, and how we brought lessons from that case-based community of practice model to helping collaborate on large-scale webinars and hopefully making them more interactive and interesting to learners. We learned a lot from Heaney over the last half hour or so about the amazing progress WHO has made through the Open WHO initiative in bringing asynchronous learning to millions of people around the world. So really going to scale, and the importance of self-paced asynchronous learning to make it so that learners around the world can learn at their own pace, at their own time, 24/7. What I'm going to be talking about is a complementary approach of synchronous learning, live, digital, virtual learning, like what we're doing right now, where we are all here in this digital space together. So really what has been motivating us is trying to make learning more accessible. This is a health equity issue of accessibility to knowledge and evidence-based information for health workers around the world, so they can provide high quality care to patients. So as I said, the ECHO Institute and Project ECHO were launched in 2003. Initially, this model was created to address our public health problem of hepatitis C in the state of New Mexico in the southwest of the United States. We're a state with about 2 to 2.5 million people. It's a large geographic area, though, and with a population spread out over our state. We have one academic medical center in Albuquerque, the University of New Mexico. And for many specialized health issues, patients would need to travel to the university many hours, often 6 or 8 hours, from rural communities to get care for things like hepatitis C. Back in 2003, Dr. Sanjeev Arora, who started Project ECHO, was one of only 2 or 3 doctors in New Mexico treating patients with hepatitis C. We had somewhere between 20 and 30,000 patients with hep C at that point. He was treating only about 100 a year, so making only a very small dent in our hep C epidemic. And he had this idea, as video conferencing was just starting to become practical and available, of what if I could connect healthcare providers, doctors and nurse practitioners across our state, say 20 or 30 of them, so no one would need to drive more than half an hour to see a provider to receive care for hepatitis C. And what if he could meet with them every week for 2 hours, a group of 25 to 30 healthcare providers, and they would present their real patient cases of hep C to him, and he, along with a pharmacist and psychiatrist, because the treatment was interferon, which causes a lot of psychiatric problems. If that multidisciplinary group could mentor these primary care clinicians over months and years, the idea was that they could become competent to independently treat these hepatitis C patients, and under the mentorship of this expert group, be able to treat them competently immediately with recommendations from the experts. So that program started over 20 years ago. It's still running today. Thousands of patients have been successfully treated, able to get their care locally. And I'll mention a New England Journal article about the study that was conducted in the mid-2000s, showing that the patients treated by healthcare workers participating in this telementoring model, they had outcomes equal to or better than the patients going to the academic medical center. So having established the evidence that this learning model, which is very similar to how medical students and residents and fellows are trained, it's essentially a virtual form of morning report for those familiar with that approach, that novices could progress to becoming experts and be local experts and provide high quality care. Other faculty at our university treating opioid use disorder, HIV, rheumatology, all who had very long referral waiting periods for patients to be seen at the academic medical center, also replicated programs along the design of this model, these case-based communities of practice. And starting about 12 or 14 years ago, other universities in the United States initially, also with challenges meeting the referral needs for their geographic areas, started replicating this model across the US, so that now there are academic medical centers and NGOs in over 48 of our 50 states implementing these programs. We've been running monthly training programs for all these partners. And in over 65 to 80 countries, there are now partners implementing these programs, which are reaching millions of learners in basically every country in the world at this point. So the goal of this model is to democratize medical and public health knowledge, to dramatically improve access to best practice care for underserved people all over the world. In terms of the global health work, I joined the University of New Mexico from the US CDC back in 2014, and I came to Project ECHO with the expressed goal of introducing this model to partners in Africa. And the first program we were able to pilot introducing the model in that context was in Namibia, and this was a PEPFAR CDC-supported HIV ECHO that launched in November 2015. So the 9th anniversary of this program is coming up in just a month. And this program launched not over almost 9 years ago. It's been running every single week for the last 9 years. When COVID happened, they were able to leverage this platform focused on HIV care and treatment to respond immediately to the COVID-19 pandemic. Additional programs in Namibia have been started for tuberculosis and other diseases. I think one of the things I want to call your attention to is all the Hollywood Square, all the screens are on here. This was 9 years ago, but even with internet connectivity challenges, the hospitals participating were able to join, and this was really meant as a face-to-face virtual learning experience. And this was a global learning community in which we had colleagues from initially 10 hospitals joining with experts in Namibia, in Atlanta, in New York, in California, in New Mexico. It was really started out as a global learning community. For really the last 8 years or so, it has been run 100% by the Ministry of Health in Namibia, and it has been a demonstration project that has been mentoring, the team that leads this has been mentoring teams in Zambia, Botswana, Zimbabwe, Nigeria, all over Africa. So it's really been an amazing success story. The ECHO model is a very simple model with 4 key pillars or principles. It's take advantage of technology like we're using today to connect people across geography within a country or across a continent or around the world. The goal really here is to amplify the scarce human resources of experts within a country to give local experts a platform to amplify their voices and to amplify the scarce human resources of local doctors and nurses and pharmacists and laboratorians. Most important is it's a case-based learning model in which participants present real cases, clinical cases, public health cases, quality improvement cases, data for action cases. The cases can take a lot of different forms. They are really then a collaborative learning experience where the experts and the peers, the peer providers all together ask questions, discuss the cases, offer advice, and it's an all teach, all learn approach. The third element is having short sharing of best practices through brief lectures, 10 or 20-minute lectures. We know that in adult learning, the evidence is good that our attention span is really less than 20 minutes. So keeping didactic lectures to less than 20 minutes has a lot better results. So these are meant to reinforce evidence-based knowledge and guidelines. And then the fourth element is having monitoring and evaluation of outcomes for continuous quality improvement. Most every ECHO program offers either continuing professional development credits or continuing medical education or different types of continuing education credits. Most every program will have at least a post-session, quick 3 to 4 minute, 10 to 12 question anonymous survey. Other programs where resources are more robust may do focus groups and key informant interviews. They may do baseline knowledge surveys, followed by knowledge assessments after 6 or 12 months. Others, there are 2 randomized controlled trials going on right now. One funded by the US CDC of a long COVID echo in the San Diego area, another of a diabetes program in the United States. And so the evaluation can take on many forms depending on resources. Just briefly to go over the anatomy of a typical ECHO session, and ECHO stands for Extension for Community Healthcare Outcomes. Most sessions are about an hour, some are 90 minutes, a very few may be as long as 2 hours, but these are meant to be low dose, high frequency learning events, ideally meeting weekly or twice a month, at least monthly. Because, as I said, these are face-to-face virtual engagements, we really try to make them professional social. We're trying to build professional social networks. So we'll do quick, brief introductions so everyone really gets to know each other. Ideally, the size of these learning sessions is maybe 25 to 50 max. Then there'll be a brief didactic or the case discussion may come first. It doesn't really matter. Each of which is followed by a brief discussion and then closing out. Some sessions will discuss only one complex case. Other programs, I was just in the Republic of Georgia last week. They've been running a tuberculosis echo for 6 or 7 years. They discuss usually up to 10 TB cases in a 2-hour session every week, and they've been doing that for 6 or 7 years. Quick discussions about their topics. As I said, this is a diagram trying to illustrate how knowledge and information flow within an ECHO community. It's an all teach, all learn approach where everyone is seen as bringing knowledge and experience to the learning network, and everyone comes to the learning session ready to learn and share, that these are multi-directional. Peer-to-peer learning is emphasized. These are experiential and collaborative problem-solving models also. They're a great opportunity to build bridges across often fractured health systems, connecting academic medical centers with ministries of health and public health institutes, connecting the public and private sectors. They're also meant to be multidisciplinary and interprofessional. We really try to encourage our partners to both include all the members, representatives of the members of a team that's needed to treat, whether it's HIV or tuberculosis or antimicrobial stewardship, and for the learners to participate, ideally as teams. So doctors, nurses, laboratorians, pharmacists, community health workers, whoever is part of that healthcare team. People often ask us, well, how is this approach different from a webinar? Well, we've all become very used to working in the webinar space. And as I said, when COVID-19 started and we began formally working with WHO in March of 2020, there was a need to deliver synchronous, real-time information to thousands of people around the world. And a webinar is the perfect digital modality for doing that. It primarily does focus on disseminating information when you're dealing with hundreds or thousands of people. They tend to be more lecture driven with more and more Q&A, and we'll talk a little bit about different approaches to make webinars more interesting and interactive. But the general purpose of webinars is information dissemination, whereas the ECHO approach, a smaller, more interactive, where everyone is seeing each other also. Webinars, generally, you don't see the participants. It's more like a large lecture hall with the lights out and a few panelists on stage. People can walk up to the microphone, but in an ECHO, everyone is ideally seen and on camera. They meet ideally very frequently, regularly, and as I said, often they run for many years at a time until the problem you're trying to address is solved. And they're a collaborative learning approach, and the participants present cases. People also ask, how is this different? Because you're discussing cases and giving recommendations. How's this different from traditional medicine or e-consults? Well, the main point is the teleecho programs are educational initiatives, whereas telemedicine, which can use the same technology we're using today, is a service delivery. It's providing care over distance remotely to a patient. All these things are complementary, and we're seeing more and more ecosystems of learning being set up. And I think we have really come to look at digital learning ecosystems in which the ECHO case-based community of practice model is one component. Asynchronous learning like OpenWHO is another complementary component. In-person learning is ideal. Having a hybrid approach often is the optimal approach, where if you can afford to bring people together for some in-person learning. And so I think we're all in a position now to really be having to think about what are these different types of learning we have available, and when is it appropriate to use each of them. And ideally, we're employing multiple approaches to support the learning of the health workers we're supporting. Telemedicine, e-consults, e-mentoring, all of these things ideally are integrated into an ecosystem of learning. Some of the benefits of the ECHO model include significantly reduced costs, not having to pay for travel on airplanes or hotels and per diems. So there's an ability to significantly reduce the cost of training, to make it more accessible to anyone who wants to learn. As Haney said, they were seeing a significant increase in the number of women participating in OpenWHO. We have seen in almost all the programs we support, there are usually over 50% women involved. Often women are not able to leave their home base for days at a time because they have responsibilities that make it difficult for them to travel. So these digital learning approaches can significantly increase accessibility and equity in terms of access. The case-based learning leads to collaborative problem solving. As I said, these approaches allow local experts to have their voices amplified. You can leverage the expertise of local experts wherever they are within a country if they can connect to the internet. And that, I think, is a huge advantage. These are flexible approaches that can be complemented by multiple modalities, as I said, in person as needed and possible, along with different types of asynchronous approaches. It allows for ongoing engagement rather than single high-dose, low-frequency learning. And we have seen there's great evidence for improved provider confidence, skills, quality of care based on their training. This is that article, and I'll put a link in the chat to it. It's an article about the outcomes of treatment for hepatitis C by primary care providers trained in this ECHO model in New Mexico back in the early 2000s that really catalyzed replication in many different fields, now over 100 different program areas. To date, there are over 600 peer-reviewed articles related to the ECHO model and its implementation, most of them published by partners at academic medical centers and NGOs around the world. And you can scan this QR code, which will link you to the archive of that. As I said, there are partners across the US and also around the world in over 65 countries, partners implementing programs that are engaging learners in over 195 countries. So there are over 1,000 partner hubs implementing almost 6,000 different programs. There have been over 2 million learners, and it's been a tremendous journey to date. As I said, this Namibia program was the first. I just want to say a few more things about that. As I said, it started as 10 large HIV hospital clinics back in 2015. It has grown now to over 50 hospitals and clinics across Namibia, basically every hospital and large clinic in the country. And programs exist for HIV, TB. There were COVID-19 programs and several others in the pipeline. They did a really nice evaluation published in Human Resources for Health a couple years ago, in which they had also done a baseline knowledge assessment. After 9 months, follow-up knowledge assessment. These was all based on their national HIV guidelines. And then they did focus group discussions and key informant interviews. And they showed really a significant increase in knowledge, particularly for nurses involved in the program. Also, they were able to get continuing professional development credits, which are required for all health practitioners in Namibia for their licenses. And they showed a significant increase in access to CPD for many of the providers across the country. This is a really nice article in the CDC MMWR about the adaptation of the HIV ECHO to respond to COVID-19. So being able to leverage that, leverage that learning platform set up for HIV for health emergencies. Just want to highlight several other programs. Vietnam started an MDR-TB program almost 10 years ago. It's still running. It's been running every week, expanded from one national program to 3 regional programs and programs on lung cancer, chronic lung disease as well. Kenya also has been running since 2016 a TB Echo program. Again, they then created pediatric TB Echo programs, TB Data for Action programs, and those programs continue as well. India has been an amazing example of a program that started also 8 years ago with a program in New Delhi focused on MDR-TB. It became formally integrated into the national strategic plan for responding to TB and ending TB. And now there are over 80 TB Echo programs run by the Ministry of Health, by the different state TB programs, as well as academic programs around India. With that, I am going to pause and hand it back to Tahini to introduce my colleague, Dr. Nada Fadul, who is going to talk about the ECHO journey in Sudan and how ECHO set up for COVID-19 were also leveraged when the Civil War happened 2 years ago. And then I'm going to come back and talk more about the collaboration with WHO specifically. So thank you. Thank you, Amy.
Thanks so much, Bruce. And yeah, there are a few comments in the chat, including Sharon asking, is ECHO an acronym? And what does it stand for?
Great. I can answer that one quickly again. It stands for Extension for Community Healthcare Outcomes. And that was kind of inspired by the agricultural extension workers that would go out to farmers and bring expertise from the agricultural university to the farmer to help them improve their agriculture. And I do see a question from Brenda about Afghanistan. And I will just say that we've been working for 4 years with the USAID-funded Urban Health Initiative that JPIGO leads in Afghanistan. And they have been running, we were able to train them remotely because this started in 2020 during COVID. And they started with TB Echo, which is still running and very successfully. They've launched programs related to maternal and child health and safe surgery, and we'll be starting an antimicrobial stewardship echo soon. So there are a number of robust programs in Afghanistan.
Many thanks, Bruce, and really inspiring session as always. And the ECHO model has existed for 21 years now, and and as Bruce showed some of the key publications, I believe there are more than 650 scientific articles on the ECHO journey, including a dozen plus on the work done in the WHO context. So these are definitely interesting references for, as I'm seeing a lot of colleagues are joining also from the research and the universities, and this is an interesting case of also operational research and building the body of evidence on lived experience of running a work in such a critical health outcomes areas and health response in our case as well. So super nice. Thanks, Bruce, for this. And I can attest that in the WHO's context, the ECHO model is so popular. We have people requesting for application of the ECHO model in their contexts and teaching sessions of this, how to apply the ECHO model in different public health domains weekly. So it's become really a very routine work area also for the WHO, and we will hear more about that in the preceding session after the next one. But now it's a great pleasure to invite Professor Nada Fadul, who's joining here from the University of Nebraska, and Nada is one of our collaborators in the ECHO model, but beyond, also in the work that you've self-initiated in Sudan as diaspora yourself, and from the spring 2023, the work of the health response in the Sudanese context has really been one of your major activities. And I'm really glad that you are able to join today and present how this learning model has worked in the middle of the crisis and conflict that Sudan has had to bear in the past 1.5 years. But over to you, Nada, for your presentation. And please also talk about your background and tell us a bit more about your professional background, because it's so fascinating. I know you well, but I hope also others get to know you. And over to you. Thanks.
Thank you so much, Haney. Thank you for including me in this session. It's great to be with you today. So I'm sharing my screen, so please let me know if you guys can see the full presentation or the presenter view.
It's good.
Okay,
Yeah.
perfect. All
Because
right.
now something came on top over it, actually. There is like a black banner.
Oh,
over it. Is that
all
the
right.
video, perhaps? Let me see.
If I
Melissa?
switch to you, is that better?
Not yet. Oh, Melissa, could it be my computer or is it for everyone?
I also see a gray box appearing over the slides.
Perhaps stop sharing and restart the share.
Yeah, let's do that.
At the beginning it was okay. Yeah.
Oh, okay, let me see. How about now?
It's good. Yes, now it's good. Yeah.
Very good. Well, thank you. Thank you, everyone. And thank you, Heini, for including me in this session. So my name is Nada Fadol. I'm a professor of infectious diseases, and I manage our HIV program here at University of Nebraska Medical Center. I'm also assistant dean for inclusive education at the University of Nebraska Medical Center, College of Medicine. And I lead a nonprofit organization by the name of Sustainable Development Response Organization that we formed in response to the emergencies in Sudan and also to help develop sustainable communities. And I'll talk about that in a minute. So this work, I say this is my after-hour work because my daily work is really working at the university, but this has been integrated in our work of the university, and UNMC has been a great supporter and sponsor of this work. So today I'm going to talk about rapid deployment of Sudan Emergency Response ECHO during the armed conflict. And I'll share a little bit of background about how we started this work during COVID-19. We'll talk a little bit about the situation in Sudan right now and the local and national responses to the conflict. And then we'll talk about the Sudan Emergency ECHO and the other programs that are ongoing and some lessons learned from that. So for all of you who are not familiar with Sudan, Sudan is in the northeast of Africa. It borders the Red Sea from the east. And the word Sudan itself refers to the Arabic expression of Bilad al-Sudan, or land of the blacks. It has a population of about 47 million. It gained its independence in 1956, and I think that's really relevant to the current problem. That's why I mentioned that. And since then, it has had three military coups and governments, with the last one lasting about 30 years, and the leadership of Bashir dictatorship. And finally, that ended in 2019 with a revolution that lasted for about 6 months or so before the dictatorship was toppled, and we had a transitional government that unfortunately ended up with another coup. And now the country is in a situation of war and a very massive crisis. So even before the current problem, the country had a major health care need, and only 2 to 8% of the GDP was spent on healthcare. And most of that was actually in the private sector, as you see here in the graph with the red line. Most of the expenditure happened to be actually in the private sector. And if you look at the healthcare access and quality index, Sudan falls towards the lower end of the spectrum. So the index of Sudan is about 45.8. It's not the lowest in the world, but it's definitely in the the far low end of the spectrum, indicating that there is a major problem with access to healthcare and access to quality healthcare. And in that context, just like the rest of the globe, rural communities, marginalized communities, racial, ethnic identity minorities, women, specifically children, face a major impact of this low healthcare access and quality. And there are so many factors that go that impact that, such as unsafe living conditions, constant conflicts, tribal conflicts, and other conflicts, and also economic conditions that have impacted the country. There is also issues with accessibility to care. Most care is focused in Khartoum, especially tertiary care. So people in rural communities have to travel hours to get to the capital to be able to access care. So health crises, when they happen, such as a conflict, the pandemic, any other outbreaks, tend to amplify these conditions massively. So right now, there is a cholera outbreak in Sudan due to flooding, and that happens on a yearly basis, and that basically brings all of these inequities and disparities to the surface, and they become very noticeable. So as I mentioned, the revolution in 2019 toppled the dictatorship. This was a massive outrising that was led mainly by women and youth in the country. They succeeded in overthrowing the dictatorship that lasted 30 years and drained the country of its resources. That happiness that was in the air, unfortunately, did not last very long. But that happened right before the COVID-19 pandemic. So the dictatorship ended in August 2019, and the pandemic hit Sudan, like the rest of the globe, in the spring of 2020. Now, there were major challenges because the public health infrastructure was pretty much demolished because of the expending all of the money on the security apparatus. So when the pandemic hit, there was not really a good system for contact tracing and deployment of surveillance systems, etc. So the second wave specifically hit Sudan really badly, and there was a lot of fear, lots of conspiracy theories, lots of misinformation out there. But what happened is that a lot of people did seek care in hospitals, even though we know 85% of patients with COVID-19 do not really need to go to the hospital. There was a need for community-centered interventions to prevent this from happening, to be able to reach patients in their communities and prevent that massive inflow towards hospitals. So myself and my friend and others in the diaspora got together and worked with the Ministry of Health in Sudan and other partners on how can we mobilize a community response to be able to fill the gap in Sudan. And this actually was a really interesting way of engaging diaspora with local authorities, with local practitioners in the response. And I feel like ECHO really facilitated that engagement, and I will talk about that in a minute. So in the diaspora, we formed something called Coalition of Sudanese Organizations Against COVID-19. And we had almost daily meetings between us and the authorities in Sudan on how to help mobilize resources, whether it was fundraising, whether it was sending supplies, whether it was training of healthcare providers in the country on how to deal with COVID-19. Now, as a result of that work, we ended up forming something, an initiative that we called the Community Medical Response Team. And the CMRT basically was developed because there was a lot of health resources, human resources that were available in the form of recent graduates from healthcare schools. Medical schools were shut down at the time, and all other institutions were shut down. So there was, semi-graduates, 6-year medical students, 5th-year medical students who were staying at home doing nothing, but also wanted to contribute to the community response and didn't know how to go about that. There were many graduates who have just graduated but have not been assigned work. There were many physicians and nurses and other healthcare providers who were not actually working directly in COVID-19 isolation centers, but their work was very slow in the community centers, for example, and they wanted to be engaged in some sort of a coordinated response. So we formed the Community Medical Response Team. We worked with the Ministry of Health, used the WHO home management curriculum. We started training healthcare providers and students on how to respond to the pandemic in their own communities. And it was very localized. So people worked in their own neighborhood, in their own city, where they're known and trusted by local citizens. And that really enabled the success of this response. I think the biggest factor to the success of this is that we had local leadership. We acted as mentors and supervisors or supporters or consultants, but the leadership of the initiative was all local. And as you can see here, these were youth. These were very young, motivated youth who wanted to help their community, who actually got the initiative up and running locally, performed the needs assessment, held meetings with local authorities, held meetings with community leaders, and were able to mobilize their own communities to help with this response. Now, Project ECHO came in after we started this initiative, and we got to meet with Bruce and the team of the Global ECHO and learn more about how we can actually implement this program. ECHO was not present in Sudan before the CMRT ECHO, so this was actually the first ECHO to be implemented in Sudan. And we were really excited about this idea of democratizing knowledge, moving knowledge, not people, because that's exactly what we were trying to do as diaspora, as healthcare authorities centralized in the capital. How can we disseminate this knowledge across the country and we get people to work in their communities, dispelling rumors, correcting misinformation, managing patients at home, and improving vaccine uptake and vaccine confidence in their communities. So ECHO seemed like the exact right platform that we needed because it allowed for this knowledge to disseminate horizontally. And we love the model of the all teach, all learn, because just because the fact that we're professors in universities in the US, that does not mean we know everything. We needed to know exactly what's happening in the ground and learn from those who are local about how we can actually optimize this response to fit the local needs, to make it culturally sensitive, and to increase the uptake locally. So this model of all teach, all learn, this bidirectional and multidirectional exchange of information was ideal for what we really wanted to implement on the ground. So we held multiple ECHO sessions between between May 2020 to October 2020. And the ECHO sessions spanned different topics. So we had sessions focused on COVID-19, such as infection control principles, but we also had sessions focused on leadership and communication and how can you engage with your community in a meaningful way. We also had mental health sessions because the toll of COVID-19 on healthcare workers was actually quite tremendous and people were not paying attention to that. Many healthcare workers lost their colleagues during COVID, and this weighed really hardly on them. And also in the midst of the COVID pandemic, there was an outbreak of hemorrhagic fever. So we had to actually also incorporate that within our response so we could be agile and respond. While we're going out to the communities talking about COVID-19 and vaccination, we can also kind of double dip and talk to the communities about prevention of hemorrhagic fever and, pest control and all kinds of things that were needed at the time. So the ECHO lasted for about 6 months. These are some of the outcomes that we were able to achieve in the first year. So we had about 35 ECHO sessions. 12 of them were actually focused on leadership and soft skills and communication. 23 of them were health focused and mostly on COVID-19. But as I mentioned, we introduced some other sessions as needed. We had a 2-hub model. So the sessions were initiated actually from the University of Nebraska Medical Center. We do have an ECHO hub here, and we delegated some of that work to Sudan. But also we collaborated with an internal hub there that was formed at the Sudan Federal Ministry of Health, who later had their own ECHOs. But this was also kind of helped as a practice ECHO for them, so that when they held their own ECHOs in the future, they had some experience and familiarity. And that also provided space for local experts and local facilitators to go and moderate the sessions from there. By the end of the ECHO, we had about 2,700 spokes or learners or attendees joining the sessions. We had 24 subject matter experts, and they were from all over the globe. Some of them were from Sudan, US, UK, Saudi Arabia, Qatar, UAE. And this was the beauty of ECHO. It was able to link all of these subject matter experts, whether Sudanese or non-Sudanese, from across the globe to engage with learners in Sudan. We had 17 facilitators from our own attendees who sometimes presented cases or facilitated sessions. And the sessions were held across 6 states. People were joining either from local offices in those states, or sometimes most of them actually joined from their own phones, which expedited this tremendously. Here are some of the outcomes that were measured through the questionnaire that we distributed after each session. So this is the pre-knowledge and after knowledge. So you can see there was a massive increase in knowledge. So majority of respondents said that they became very knowledgeable or extremely knowledgeable after the sessions, compared to 20% or so saying that they were very knowledgeable, extremely knowledgeable before the sessions. We also asked them how relevant these sessions are to your daily work. And again, the majority of respondents said this is very relevant or extremely relevant. And we also asked them if you would recommend this session to a colleague. And again, a very overwhelming majority said definitely yes or probably yes. And the other question that we asked, will you use what you learned in your work? And that was really important to us because we didn't want this knowledge to just go unapplied or unnoticed. So again, a very good majority said that they will apply this knowledge, definitely yes, or probably yes. They will apply this knowledge to their work. And that was really important for us again, because this was a massively, a rapidly moving target. So we need to make sure we apply this knowledge. So this is what we accomplished in the first year. The CMRT was able to manage 77 patients on home isolation. And these patients were referred to us from the isolation center. They go to the hospital, they're deemed stable, they don't need to be admitted. So then they're referred to the CMRT to follow them remotely at home. So we made phone calls to patients on a regular basis, assessing their health status and making sure that they can stay at home and they don't need to go to the hospital. We also held 150 COVID-19 awareness campaigns, and these were held in local schools, in mosques, in churches, in markets, wherever people were. We went to them to hold awareness sessions. Many of these were actually about vaccination. Once vaccination became available, we shifted our training and awareness sessions to talk about COVID vaccination, because there was a lot of misinformation and conspiracy about COVID-19 that vaccination that we needed to dispel. As a result of that, actually, we held mobile vaccine clinics. And this idea actually stemmed from one of the ECHO sessions. One of the attendees came up and said, I was holding an awareness campaign with women at the bread line and talking to them about COVID vaccination and the importance of getting vaccinated. And these women who were waiting on a line to get their bread, just kind of went off on her and said, we want to get vaccinated. It's not that we don't believe in vaccine, but vaccines are not accessible to us. We have to take a bus and go a long distance to be able to get to the nearest vaccine clinic. So she brought this dilemma up at the session. And this is the beauty of that interactive exchange of information, that there were people there at the session from the Ministry of Health, there were subject matter experts, there were other attendees who then started talking and brainstorming about how we solve this problem. And we started the discussion during the ECHO session, and the idea of mobile clinics came up. Why can't we take vaccination to people? This is not a very difficult problem to solve. And we have done it here, even in the US, where we took vaccination to underserved communities and we started vaccinating them there locally. So then we followed up after the session with the Ministry of Health and with other authorities, and we started our first mobile vaccine clinic in that neighborhood where that woman was. And in one day, we were able to vaccinate 2,000 people. And that was a major success that actually prompted other vaccine clinics to be implemented across the country, especially in low resource settings in far-to-reach areas. And by the end of the year, we were able to deliver 25,000 doses of COVID vaccination at 65 mobile vaccine clinics. Now, through this work, we developed multiple partnerships. This work we could not do alone without several partnerships from governmental, NGOs, private entities that collaborated with us, and of course, fundraise for this effort to continue. These are some of the photos from some of the vaccine awareness campaigns and sessions. In the bottom left, right corner here, you can see a woman being vaccinated in her own home because she was not able to get to the vaccine clinic. In the middle here, this is a vaccine registration site. We were sitting outside under a tree registering people for COVID vaccination. On the top there, you see people actually going around the neighborhood with the vaccine in the blue container under the right temperature to be able to vaccinate. And the top left here, you see a student sitting with a farmer, a shepherd actually, and talking to him about the vaccine clinic that's coming to town next day. And it's really important to go get vaccinated. And again, what made this really effective is that these students were from the neighborhood. They knew the people, they knew where to find them, and they were able to outreach to them. Now, this effort was highlighted in multiple media publications talking about how students and volunteers in Sudan mobilized to address the COVID-19 with the assistance of virtual training from their ECHO program. So I'm going to share some words in the students' voices so that you can hear it from them directly. And I'm going to focus here on
So now, can you
ECHO.
tell me, how did you benefit from the ECHO program?
And let me know if you can hear this.
Yes, we did.
CMRT experience.
So now can you tell me how did you benefit from the ECHO program?
The knowledge that we gained has helped us engage our communities better and better tackle problems and concerns in our communities. It also has helped us see them in different angles and perspectives. This has especially been helpful in dealing with a very, well, you could say unpopular disease, which is COVID-19, of course. Using the skills that we learned, we were able to convince more people to listen to us when we talked to them about the importance of the preventive measures against COVID-19. That added to the vaccination campaigns that the different teams carried out all over Sudan.
We learned so much from the ECHO program. We had the opportunity to meet a lot of subject matter experts and improve our knowledge, our communication skills. CMRT gave us the opportunity to travel, to learn, to be engaged in our community, and to give something to our Sudan.
Well, when it comes to the ECHO, I think I might wait impatiently for the ECHO sessions to come and to meet the subject matter experts, to learn from them and so. And of course, in the ECHO, we find the solutions and the answers for our questions regarding the problems we face in our community, in our local level. So to summarize, I think I would say ECHO has gained us the skills and the knowledge to handle our problems and our community during the COVID-19 pandemic.
What is
So yeah, so these are all, as you can see, young students. Some of them are in their final year of medical school. Some of them were still in their, say that the last speaker was in her third year of medical school when she participated in the program. And the program really made an impact on them, and we were able to continue the work afterwards because of the success of the CMRT COVID ECHO. We actually shifted the program afterwards to community-oriented primary care because the same human resource was available and they wanted to do more for their community. So we started training them on primary care and how they can conduct primary care in their community setting, especially preventive care, because that's not really a common setting in Sudan, that people don't go to the doctor unless they're sick. And we needed to start some preventive outreach. We then had a leadership and peace building ECHO training for the volunteers in collaboration with Conscious Coalition, which is a leadership training organization here in the US. University of Jazeera, which is the largest rural primary care university in the country, held their own primary care ECHO, and we collaborated with them in getting that off the ground. The Sudan University of Science and Technology actually had an ECHO focus on engineering, and they formed a team. They called the team's Community Engineering Response Team, the CERT, and they trained them on waste management because waste is a big problem in Sudan. And finally, the Federal Ministry of Health started a patient safety ECHO. These were all the ECHOs that were done in 2022. Unfortunately, in 2023, the war started and we could not continue that work that we started in 2022, and we had to shift gears. So this is our model. Bruce talked about this a little bit. So this led us to form a couple of entities. So the Sudan ECHO Center of Excellence that linked all these ECHOs together and provided resources for the ECHOs, training for subject matter experts, training for facilitators. We shared learners across all these ECHOs, so the same learners could participate in several ECHOs at the time. And then we formed the Sustainable Development Response Organization that was registered in Sudan to implement the projects that we were talking about. So whether it's the COVID-19 project, whether it's the community-oriented primary care, whether it's the peace engineering, waste management, we wanted to get these projects under one umbrella so we can effectively implement them and fundraise for them and seek grant funding, etc. So the sustainable development model seems like the right framework to put those under, and that's how we organize the organization to link the training, the capacity building with the projects that we're implementing in the community. One of the problems we faced is internet connectivity, which is a big problem in Sudan. So Zoom does not operate as efficiently as operating for me here now. So we shifted our programs actually to the Telegram platform. And for those who are not familiar with Telegram, it's actually a social media platform, but it's very efficient for training because you can share a screen, you could have a video conference, You can have multiple learners join the session. Thousands of learners can join the session simultaneously, but it has a very low bandwidth requirement. So it does not consume a lot of gigabytes for the attendees, and therefore it's very cost friendly for people in low middle income countries. And this idea actually also came from our ECHO coordinators in Sudan. Hadil, who is now the director of Sudan ECHO Center of Excellence, has held several trainings for her colleagues in the university and tutoring sessions on Telegram. And she came to us and said, why can't we use Telegram for this? So we tried it on several ECHOs and it worked. So then we formed a group on Telegram for our ECHO Center of Excellence. And that group grew from a few hundreds to 5,000 members by the end of 2022 because of all the ECHOs that we were holding. And the beauty of that group, it actually continues after the ECHO session is done. So it serves as a community of practice where people can still communicate after the ECHO session. We can announce the upcoming ECHO sessions. We can send surveys and feedback reports through that group, which help us continue the engagement with our attendees. As I mentioned, in April 2022, the war erupted in Sudan and kind of stopped all the work we were doing for development. At the time, we had to shift our gears to respond to the emergency that was happening. So the war had devastating effect. By now, there is about 24 million people or 25 million people in need of humanitarian assistance. 2 million are displaced outside of the country as refugees in neighboring countries, and 8 million are displaced inside the country in other zones. All the red here in the Sudan map is areas of active conflict as of the publication of this report, which was September 19th. And there is a famine now in the country. There are 25 million people facing acute levels of food insecurity, according to IPC. So it's very catastrophic, it's very disastrous. So immediately after the war, I reached out to Bruce and other colleagues at Project ECHO, and I said, hey, can we do something about this? Emergency medicine is not a specialty in Sudan. So we needed to figure out how can we respond to the emergency using the ECHO model, using the platform that we already have in place. And there was already an experience with Ukraine, as Bruce already mentioned. So we collaborated with the global ECHO team. They brought colleagues from WHO, from ICRC. We had a meeting, and we decided to use the WHO BEC curriculum. And we deployed this training 2 weeks after the war started. So the war was April 15. April 29 was our first session. Dr. Sean DeAndrea, who had helped launch the Ukraine program, was our co-director of this program and was able to get this moving along very quickly. Our Telegram group, once we announced the program, exploded from 5,000 to 14,000 participants in the Telegram, showing that there was real hunger for this training. And by the end of the program in October, within 6 months, we delivered 43 sessions. We had twice weekly sessions delivered through the ECHO platform, and 23 of them were actually delivered by WHO EMRO and WHO Sudan offices. They came and collaborated with us because they needed a platform to deliver their case management series of how to handle outbreaks and emergencies during the conflict. And this served as a very effective platform for them to be able to deliver that. Again, by the end of the program, we had about 2,700 synchronous attendees, but we were able to put all the material, all the recording sessions, all the presentations, all the tools in a Telegram channel where people can access it and view the recordings asynchronously if they didn't have internet at the time, etc. And there were 80,000 clicks on those material that was, or the videos that we put in the Telegram channel, showing also high uptake of the asynchronous material that was available to people. So some of the outcomes, very similar to our other ECHOs, people thought that their knowledge increased significantly after the session, which is shown here in orange, compared to the teal before the session. People again said they will use what they learned in their future work, and they would recommend the session to their colleagues. So they rated the sessions really highly, and majority of them said they would recommend the session to their other colleagues. Now, what's really important is that this work actually resulted in community intervention. So at the time we were implementing the ECHO, we started launching mobile clinics, very similar to what we did with the COVID-19 vaccination, but these clinics were actually located at displacement areas and displacement camps, specifically targeting people who have been displaced to provide them with chronic disease management, with minor, it's almost like acted like an urgent care where people with respiratory illness or minor infections, minor injuries can go and seek health assistance. And we were able, by the end of the ECHO, simultaneously implementing this within the first year, we're able to reach 20,000 patients in these mobile clinics. And the material that we had in our ECHO sessions or in the Telegram group was a really good reference for people to go back to. So if they had a case of cholera, they could go back and see what are the infection prevention recommendations, etc., so that they can implement that in their clinics. Again, you can see these are held in tents under a tree, wherever we're able to reach people who are displaced. We held these clinics to be able to reach them. Now, we didn't stop there. So after the emergency ECHO concluded in October, we immediately began implementing other ECHO programs based on learners' need. So while we were launching the ECHO in the Telegram group, we had polls asking people what other topics they wanted covered during the ECHO sessions. And sometimes we had to change the topics almost weekly to meet what the learners wanted. But after the ECHO concluded, even those 43 sessions were not able to meet all the needs that we had in the community because the needs were changing. There was a massive issue of gender-based violence during the conflict. Multiple rape crimes have been reported, and many patients were actually hesitant to seek help in the healthcare facilities because of all the stigma associated with rape and all the inefficiencies in the healthcare system dealing with those specific problems. So we held the program on sexual reproductive health and gender-based violence in collaboration with SAIHA, Society of Women in the Horn of Africa, and the Federal Ministry of Health. And that was a hybrid program. Some of it was in person and some of it was through ECHO. Again, the WHO EMRO and WHO Sudan held the cholera response training program through our ECHO. And that was targeting the Red Sea state. And we actually had volunteers holding oral rehydration corner in clinics in that area after they completed this training. We had a research ECHO because volunteers wanted to collect data about what's happening on the ground, and they wanted to know how to do that in a way that's systematic and publishable in the future. So we actually had a research ECHO, 2 phases conducted. Sudan Medical Specialization Board, which is the main agency that provides specialty training in Sudan, a specialty certification, was not able to reach its residents across the country because of displacement. Some people are in the country, some people are outside of the country. So they wanted a virtual platform to be able to reach all learners and to provide continuous education on all the modules which are mandatory for residents to complete in order for them to finish the residency. So we collaborated with them. We're using the ECHO platform actually as a continuous education platform for the Sudan Medical Specialization Board, delivering courses about professionalism, radiology, all the continuous education courses that residents need. We also had a very creative and innovative ECHO that was developed in collaboration with Project ECHO at University of New Mexico about resilience for healthcare providers, because we often forget about healthcare providers and the impact, the psychosocial impact, the mental health impact that they suffer from such conflicts. So we needed a program that can help them, process through what they're going through. And there was a resilience ECHO already held by colleagues from psychiatry at University of New Mexico. So we collaborated with them. We used their material, their presentations to train our colleagues in Sudan with local experts holding that training. We also had a mental health response ECHO focusing on psychological first aid. So for patients who come to these displacement camp clinics, how do you provide psychological first aid for them? And that ECHO just concluded a couple of weeks ago. Right now, we actually have an HIV wellness during crisis ECHO ongoing right now because patients with HIV have been displaced across the country. They used to go to VCT centers, which are very specialized in HIV treatment, but now they don't have access to those VCT centers. So we have to train healthcare providers in general about how to address issues related to HIV care and management. Now, all of these ECHOs have been conducted in the past year, and that just speaks to the agility of the ECHO program on how to change and respond to the local needs that are happening. Anything from research, which you wouldn't think that's needed during conflict, to mental health and gender-based violence, which are very needed in conflict. So in summary, the CMRT inaugural ECHO in Sudan enhanced diaspora engagement through capacity building and bilateral knowledge exchange with our colleagues in Sudan, but local leadership and ownership is really what allowed for this to be translated into community projects. And that's really important, to have the local people on the program, run it, modify it as they see fit, and keep the diaspora, keep the global experts engage in a way that's more of telementorship, which ECHO provides that platform for. The pre-existing platform that we had, the Telegram group, really enabled us to quickly deploy this program, and using the existing resources, the existing subject matter expert from the Ukraine program, and just shift that to help modify it to help the Sudan crisis. And the agility of this ongoing community of practice helped us to shift from one program to another based on the needs that they identify. And again, I cannot speak enough of localization of humanitarian response, localization of training. This can really improve the quality and improve the sustainability of these programs, because the local people feel like this is our program, this is what we need, and this can be modified to meet our needs as well. And what I feel really dearly about is that the lessons that we learned from this ECHO, whether it's the COVID-19, whether it's emergency response, can be used later. I'm a very optimist person by nature, so I'm looking forward to the time when the war stops in Sudan, when people are able to resettle back in their communities. And we could use a lot of these lessons learned, the agility and the resilience, on how can we build the re-country after the war stops. So thank you everyone for your time, and I'll hand it back over to you, Hani. And this is a picture of some of our volunteers in the northern state. And they took a photo after conducting a mobile clinic there. And just, I owe it to them for the work that they're doing. I'm just merely their voice, and they take credit for all the work that's happening on the ground. Thank you very much.
Thank you, Nada. This is an amazing testimony of strong efforts and work that you have inspired the rest of the teams and work areas to join, and it's been critically important and run just in time. So we are in a full awe of the courage and perseverance that you put yourself personally into this pursuit of teaching in the times of the war and crisis and across the health emergency topics. And it's really nice also our WHO office then later joined in providing experts for the sessions and have been able to also adopt this model, so that it also the sustainability hopefully also comes from the fact that more of the personnel also from other agencies like the World Health Organization sees how well this works and can adopt it for the other areas. So really thanks for this, and it's an amazing testimony of the work, as said already, and really great that you are ready and willing to talk about it, and you have documented it so well, and the results are quite massive. So amidst of all the events, very adverse events, there's been such a keen uptake of learning across the topics and thematics. Let's keep checking the Q&A if anybody has questions, so we can also, we've been answering also directly and in the chat. But really many thanks for this, Professor Nada, and we look forward working more with you, and it's a nice consortium between the people here also and other partners who've done the similar work in the similar settings. And I hope this is also a model that we can multiply in other countries in the region and for other types of emergencies, including in Horn of Africa and the rest. And think that there is the need to talk and present this, so to inspire others. And you've definitely done it again, Nada. Thanks for this. Many thanks.
Thank you.
Let's then go back to Bruce, who's going to talk about the other examples of work between the ECHO, the project ECHO, and the World Health Organization. And we have a few more great stories to share for the rest of the session today. So Bruce, over to you.
Thank you, Hani, and just want to thank Nada and her team for their incredibly inspiring work, for the innovation. They've innovated on multiple fronts. One of the really fun things about this ECHO network of networks and partnerships is that our partners are innovating all the time and bringing new ideas and better ways to do things. Innovations like using Telegram to be able to rapidly to reach people with even lower bandwidth than Zoom is able to reach people. The innovations are countless. I also want to say, you know, it's sort of an irony as Nada was explaining the journey in Sudan over the last 4 years. They created their first ECHO programs to respond to the COVID-19 pandemic 2 a health emergency. They were running their programs for several years when the Civil War broke out, and they then leveraged that network to create a program within 2 weeks to respond to conflict and the need for emergency medicine training, public health emergency around the cholera outbreaks and other public health issues that came up related to the conflict, as well as the trauma training needs that were immediate. But what had become their ongoing program was born out of a public health emergency. They then had an armed conflict that required another type of emergency response. But having that network in place allowed them to be agile and to respond rapidly. And I'm going to bring up a number of examples of other networks that we have seen. This is one of the great lessons learned. It's one of the things that was highlighted in the guidance you mentioned, was just published by WHO about just-in-time learning. Having these learning networks in place before the emergency, whether it's a public health emergency or a natural disaster or conflict, is much better than trying to stand these learning networks up in the moment, which can be done, but is more difficult and not as optimal. And I think the program in Sudan benefited so greatly from having that huge, extensive learning network in place that when sadly that conflict unfolded, she was able to leverage a large network and grow it rapidly as well. So I want to just talk for a few minutes to continue, but focus really on the WHO collaboration that we've been engaged in over the last 4 years, and just to talk a bit about that journey. So we had been in dialogue with WHO in Geneva and in Africa for a number of years, even before COVID broke out. But it really was in April 2020 when COVID-19 was unfolding across the globe that WHO Afro, because of relationships that existed there with team members like Fausto Moshe, who was before working for WHO as a laboratory advisor in Eastern and Southern Africa, was the head of the national laboratory in Tanzania, had implemented the first laboratory echo in the world. Back in 2016 or 2017, she then became the laboratory advisor for Eastern and Southern Africa when COVID started unfolding globally in March, April 2020. And WHO Afro, the Emergency Preparedness and Response Program, was looking for ways they could not travel to rapidly disseminate information about COVID-19. She introduced us to the Emergency Preparedness and Response team and brought up the idea with them, that asked if we could collaborate to rapidly stand up a series of webinars to reach thousands of people across Africa and beyond to help WHO Afro respond to the COVID-19 pandemic. So beginning in 2020, launched a series of collaborative webinars with WHO Afro. Around the same time, we were working with the US CDC Infection Prevention and Control team and the IPC team in Geneva. Again, there was a need to rapidly educate clinicians across the world on infection prevention and control. And so we started working with the IPC team in Geneva about that same time of April 2020. And then launched a webinar series in May on IPC that has continued for several years and continues up until now, and in a different format. It's evolved. By December 2021, after about 2 years, we were working with about 15 different teams at WHO Geneva, as well as in Africa and Ciro, and helping primarily with interactive webinars, but on a wide variety of topics, from COVID-19 vaccine introduction and scale up, and doing interaction reviews, help to not only make them information dissemination, but more case-based learning and interactive with a lot of polling, and having more case-based presentations, et cetera. Some really interesting innovations happened around things like the infection IDSR program, infectious disease surveillance and response program, which traditionally had been in-person training of cohorts of about 100 people that AFRO had been doing for years. When they were not able to implement those in-person trainings in the summer of 2020, we collaborated together to create a webinar version of that IDSR training. And while they had been training about 1,000 to 1,500 healthcare workers in IDSR in Africa for years, through that online synchronous webinar training, we put together a course that had 12 sessions over 3 months, and they reached about 12,000 participants and ran them in 3 different languages: English, Spanish, and Portuguese. English, French, and Portuguese, and really were able to massively scale up engagement on that topic of IDSR. And then, as Haney said, in August 2023, we became a WHO collaborating center for digital learning in health emergencies and had our first anniversary a month or 2 ago. So this is just a screenshot from the first collaboration back in April 2020, a session about COVID-19, including case management, epidemiology, IPC, engaging colleagues across Africa who are experts, as well as some colleagues in the United States. And they reached over 1,000 participants from 58 countries. It was really quite extraordinary for us. We'd never supported a webinar with so many participants. And it was eye-opening to our colleagues at WHO AFRO as well. And I really want to thank Bukari Bonguku, my colleague who's the Learning and Capacity Development Unit Lead at AFRO, who we worked with, often supporting 3 webinars a week in 2020. It was really quite amazing. We wrote a really nice paper together about the partnerships involved in rapidly scaling up trusted information dissemination in a health emergency. And I'll share a copy of that. This is just a summary of the participant data from the first CDC-WHO COVID-19 infection prevention and control webinar series, which was in May of 2020. Again, over 1,000 participants, in this case from over 122 countries. We were able to offer simultaneous interpretation in 5 languages. The ability to run these massive synchronous learning events with multiple languages, and the changes in technology with things like Zoom that integrated interpretation services, making that easy to add additional synchronous interpretation, has been revolutionary in being able to engage learners from across the world in being able to make it more accessible by having interpretation. Again, the IPC team published a really nice article about this learning series that went on for about 6 months. and the lessons learned from that in providing IPC training across the world in support of the response to COVID-19. At the end of 2020, we started collaborating with the COVAX COVID-19 vaccine team and Shoshana Golden and her team at WHO. This is a collaboration of WHO, UNICEF, Gavi, Boost. Again, one of the amazing things that came out in the COVID-19 pandemic were the multi-organization collaborations. It really was an amazing, inspiring period of collaborative activity, and being able to have multiple organizations working together rapidly to support education around the world. In this series we did with the COVAX team, this was a 15-session series, started in January of 2021 to help support the rollout and implementation of COVID-19 vaccines around the world. There were over 3,000 participants from over 181 countries with just incredible participation. We had not only the live webinars, but also the TechNet 21 Community of Practice, which was an asynchronous online web-based interactive space that WHO had run for years. We also had Telegram groups for asynchronous messaging communication that complemented the webinars and the TechNet 21 platform. So we were reaching learners through multiple different avenues. And so that was really a lesson through this series, that having these different communication modalities became a kind of routine for engaging different learners. Some people used all those modalities. Some people would just use one or two of them. Again, we published a nice paper together looking at the lessons learned from that experience of that 15-session series. And we can share that. And then we later in 2021 had a smaller series focused on interaction reviews. And this series, which was looking at lessons learned from countries using case studies related to their interaction review process, was another COVID-19 vaccine, WHO, UNICEF, Gavi collaboration. And in this paper was a nice summary of lessons learned from that experience, which was a smaller engagement, but included about 700 participants from 129 countries. Again, amazing that it has become routine to be able to engage learners from over 100 countries in these learning events. At this point, we've been working with WHO Geneva and AFRO for 4 years. We've helped collaboratively produce over 400 digital learning sessions that have engaged almost 200,000 participants from 195 plus countries. We've offered up to 10 different languages, depending on what was needed in simultaneous interpretation. These programs have primarily been related to emergency preparedness and response. There's a series related to public health laboratory strengthening, antimicrobial resistance national action plans. We've been working closely with the nursing and midwifery team, the infection prevention and control team, COVID-19 immunizations, working with the HIV team on advanced HIV disease, and supporting care of patients with advanced HIV disease in the midst of global health emergencies, and have been collaborating on a long COVID learning series for the last year now. All the sessions have been recorded and archived in different places. many through WHO websites, others through our Project ECHO websites. There have been over 75,000 views of these recordings. One of those sessions, that infectious disease response, IDSR, surveillance and response series, had over 14,000 views, which for us was a lot. I know Haney, in going over OpenWHO, the numbers are much larger, but anyway, the scale and reach of these digital learning programs has been daunting and amazing. This is my last slide, and just want to review how we are supporting WHO as a collaborating center for digital learning and health emergencies through both direct collaboration on digital learning events and through training of WHO staff and other UN agency staff on digital learning, synchronous digital learning specifically both the virtual community of practice approach and webinar approach, professionalizing digital learning for workforce development through these different synchronous digital modalities, and just generally being a partner of WHO in this learning journey that we're both on. Again, we've learned a tremendous amount from Haney and her team, the Learning and Capacity Development team of the Health Emergencies Program. And with that, I'm going to bring this formal part to a close, but I do want to just mention super briefly, I know we don't have a lot of time, a couple other related projects. So one of them is, I did share with everyone that NADA's program on Sudan, an article about that program, as well as a Ukraine trauma conflict training program. Case studies related to those were just published last week in a special Frontiers topic that Haney is the editor for on just-in-time learning, and I put a link to that and would bring that to your attention. I also wanted to say that in terms of this issue of setting up these learning programs and having them running, and then when a health emergency happens, being able to leverage them rapidly. There was a wonderful program, and we had hoped to have colleagues from Uganda, from Seed Global Health, who've been running an emergency medicine echo for over 3 years now. When the Ebola outbreak happened 2 years ago in Uganda, they had been running this emergency medicine training program, connecting all the regional referral hospitals and up to several hundred district hospitals in Uganda. They were able to rapidly engage that network. They actually used a wonderful hybrid approach to train healthcare workers on Ebola. They used the OpenWHO asynchronous courses. They then held sessions for 3 days for people that had completed those OpenWHO modules. They were invited to participate in 3 days of, I think, 2 to 3 hours per day, live distance learning sessions on Ebola care and treatment. And then anyone that completed those was invited to an in-person training in Kampala. And it just represents an example of a nice integration of multiple learning modalities: asynchronous, synchronous virtual, synchronous in person, and being able to rapidly take advantage of materials on OpenWHO that were available, in combining that with interactive collaborative learning. And related to that, in a way, on a similar vein, is a series that we were asked just 2 weeks ago to work with WHO Geneva, AFRO, and Africa CDC to support MPOC's case management webinar series. First session launched last week. I know that the MPOC's training materials on OpenWHO have been used as background material, and this webinar series is meant to complement that and bring it up to date through these synchronous learning events. And I think these are just great examples of being able to draw on these different materials that exist or that need to be created rapidly, to leverage partnerships also that existed, and be able to move quickly to provide learning as needed. So with that, thank you, Haney, and back to you. I know we have a few minutes. Hopefully we'll have a few more questions.
Thanks a lot, Dr. Bruce, and also appreciations to Dr. Nada. It's really nice to exchange and bring these collaborative spaces and modalities of work into the limelight and share it with the participants here today. We've had attendance by more than 100 individuals coming and going in the session, and we will make sure that the recordings are also distributed and disseminated widely. It's really inspiring to see that how much we've been able to collectively achieve, and by not hesitating at all that we're gonna walk many more journeys together, not only in this just-in-time learning response, such as the MBOX response now, but also in other health emergency events and topics, infectious diseases in particular, but also other types of a crisis. And I think there is a lot here to drill into more details even, and there are many other very nice case studies like the one you mentioned from Uganda, but also work flows from Ukraine and other responses where the learning has been really utilized very strategically and on an ongoing work programs. And I think that's the role of us, the capacity builders in health emergencies, to try and walk that journey to make available the learning events when they are probably time is compromised, but when they are needed the most. And I think here, anything that we can establish very successful case studies and examples of learning journeys during the emergencies, I think there is always a big benefit from sharing and exchanging. So thanks for this great session contents. I think we've all addressed the questions that have come to us so far. We've had also very inspiring chat room here with colleagues from around the world sharing their special materials and your links, and even the work areas that you're working at. So we're really grateful that you could join today, and we hope that you will be involved in this network of learning champions. You could explore the ECHO models also from the ECHO Institute website, and probably be inspired by this kind of a modality to join also in the same methodological choices of work when delivering the emergencies learning. So I don't see any questions. I'd like to appreciate the Consortium for Universities in Global Health for having organized this session and provided us a platform to present. Your universities are members of CUGH, I believe, and it's great that the active universities are attending also through these presentation means, and really thanking both Dr. Nada and Dr. Bruce for this session, thanking Melissa and Susan for the session support here, and want to invite you also to join me in my LinkedIn, where I'm very active and where I also brainstorm ideas, and hope to get your feedback through that mean. And I'm sure as practitioners in emergency learning and public health, the surroundings and actors are never enough, and we need more active actors, learning champions in this field, and hope to see you in these contexts and exchange actively as well. So many thanks for this attendance and many thanks for the session, and look forward for more exchanges in the future and potentially also in the next CUGH next February. So lovely to see you all, and thanks for Bruce and Nada for your excellent sessions. Thanks so much.
So much.
Thank you, Haney. Thank you, Nada. Really a
Thanks
pleasure.
everyone. Thank you.
Thanks everyone for
Have
joining.
a lovely day. Thanks a lot.